احنا سامعين حضرتك.
السلام عليكم ومساء الخير عليكم جميعا. يسعدني ويشرفني اني اكون اليوم معاكم في المؤتمر، وهي اول مره بشارك في مؤتمر من مصر العزيزه، وانتم كلكم بشرفني وجودي معكم. حابه اتشكر الدكتوره البروف هالة جودة على دعوتها الغاليه الي، وحابه اتشكركم جميعا خاصه الاخ محمد زنون على كل الترتيبات وعلى جهودكم العظيمة في عمل مؤتمر رائع و covering most important topics في البيدياتريكس. يعطيكم ألف عافية، وأتمنى أنه إن شاء الله you enjoy the topic that I will present today. وحابة كمان أتشكر بروف ميسة صالح زميلتي الغالية والعزيزة برضو على جهودها معنا برضو، وعلى كل مشاركتها في دعمي ودعم المؤتمر.
احنا اللي بنشكرك يا دكتورة منال، كل الشكر لحضرتك. وبصراحة حضرتك بنشكر حضرتك على اختيار الموضوع الحقيقة موضوع رائع جدا، وفعلا عاوزين كل شباب الأطباء والناس كلها يركزوا معانا في موضوع حضرتك. not all diabetic children are type 1 diabetes mellitus، وعشان نلقي الضوء على النوع الثاني اللي ساعات بيبقى undiagnosed. لك كل الشكر، ونتمنى التوفيق لحضرتك يا رب إن شاء الله.
إن شاء الله. شكرا جزيلا أخ محمد، وشكرا بروف هالة. My talk today about not all diabetes in children is type 1 diabetes mellitus. الأغلب بيظن إنه المرض السكري اللي شائع وجوده في الأطفال هو فقط أو لازم يكون الإنسولين ديبندنت diabetes أو type 1، على الرغم من إنه صح هو الأغلبية العظمى من حالات الديابيتس في البيدياتريكس هي type 1، لكن هذا لا يعني إنه في حالات أخرى من الديابيتس موجودة. We need to keep a high index of suspicion about it in order for early diagnosis or early treatment. وفي some different treatments tailored according to the type of diabetes that we will discover, especially the neonatal diabetes والmoody type of diabetes. They have a different treatment. Some of them have a different treatment option other than the insulin. So in my talk, we'll talk about type 1 plus other types of diabetes and the classification according to the American Diabetes Association criteria. The objectives of my talk is introduction, incidence and prevalence of pediatric diabetes, criteria to diagnose diabetes, what are the recent or the updated HbA1c recommendation to be used for diagnosis of diabetes, etiological classification of diabetes. We all know that diabetes is a complex and a chronic illness requiring a continuous medical care. It's a multifactorial risk reduction strategies beyond the glycemic control. The treatment of diabetes مش بس related للdiabetologist أو endocrinologist أو even the pediatrician. It's a huge teamwork, including the diabetologist or physician, the diabetes nurse educator, plus the dietitian. And I think Dr. Inas Akid, if she will talk to us about management of diabetes meal plan for pediatrics diabetic patient, she will have or she will need many presentations to cover this topic. Ongoing diabetes self-management needs an education and support, and these are critical to avoid the complications and to reduce the risk of long-term complications. We all know that the numbers of pediatric cases or patients affected with diabetes are increasing worldwide. The numbers اللي عم نشوفها على الشاشة هي numbers recorded in 2015 for the patients affected with diabetes throughout the world. And we can see in هذه الأرقام اللي موجودة في السيركلز. الأرقام الموجودة في المستطيلات اللي below the circles are related to the expected number of affected patients with diabetes in 2040. So we can see that almost the numbers are doubling, and this is really critical. This indicates that diabetes is becoming a pandemic through all over the world for pediatric and for adults. Here I would like to highlight an incidence of diabetes mellitus in pediatric age group, and this have been obtained from the search study for diabetes in youth study group, and we can see that في bimodal distribution للأفكشن of pediatric diabetes. البيك الأولى في 2 peaks للincidence of diabetes. البيك الأولى تحدث عادة في mid childhood around the age of 5 to 9 years, and the other peak is around the early puberty after the age of, from the age of 10 years and below and above. The green indicates type 1 diabetes, bars, and the green bars indicates the incidence of type 1 diabetes, and we can see that it's high compared to the incidence of type 2 diabetes اللي هي عبارة عن the blue bars usually seen from the age of 10 years and above or earlier, especially with the increasing number of pediatric obesity. The prevalence of type 1 or type 2 diabetes in children and adolescents, this was studied by the US between 2001 to 2019. And we can see that, again, this have been obtained from the search study group. And we can see that type 1 diabetes, the incidence during 2001, the blue bars, was less compared to the incidence detected in 2019, especially among the white ethnic or white people, and also throughout all the ethnic groups. بالنسبة للtype 2 diabetes, also the number or the prevalence of the pediatric cases affected with type 2 diabetes is increasing or has been increased in 2009 compared to 2001. And if we will study them now currently in 2020 and 2021, I am sure that the numbers will be more than whatever has been studied or detected before. So in pediatric endocrinology practice, diabetes account for 50 to 60% of the workload. Almost half of our work is only for pediatric diabetic cases. And diabetes in general, it's characterized by the hyperglycemia, regardless of the cause. So this hyperglycemia is a result of either impaired secretion of insulin because of the pancreatic beta cell have been affected, and this is usually seen for type 1 diabetes, or resistance to the effect of insulin in the liver, muscle, and the fat cell, which is exceeding the capacity of the pancreas to compensate for this insulin resistance. And this is the characteristic usually of type 2 diabetes. Criteria to diagnose diabetes in pediatrics and in adult has been recently revised. واحنا كلاتنا بنعتمد او الاغلبيه منا بيعتمدوا مني ومن زملاء يعني انا وزملائي من البيدياتريك اندوكراينولوجيست والديابيتس وديابيتولوجيست عاده we usually depend على الامريكان Diabetes Association criteria and the standard of medical care in diabetes, which has been recently updated just in January 2021. The criteria to diagnose diabetes has been recently updated, and it is 4 criteria we have to diagnose diabetes. Any one of them present, it means this patient, either a diabetic or adult, has diabetes, regardless of the cause. First criteria to diagnose diabetes is an A1C. If the hemoglobin A1C is more than or equal to 6.5, this indicates diabetes. لكن الشرط إن this HbA1c should be done by a method that is NGSP certified, and we will talk about it, and standardized to the TCCT study assay. Or fasting blood glucose is more than or equal to 126 milligram per deciliter or 7 millimole per liter. And fasting is defined by no calorie intake for at least 8 hours. 8 hours is enough as a fasting to check the fasting blood sugar. We don't recommend fasting beyond 8 hours to check it. Or 2 hours plasma glucose more than or equal to 200 milligram per deciliter, which is 11.1 millimole during the OGTT test. And this oral glucose tolerance test should be done as described by the World Health Organization by giving a glucose load of equivalent to 75 gram of glucose dissolved in water. طبعا الدوز في البيدياتريك مختلفة, it's per kg, بس recommended oral standard is to do the OGTT according to what is described from the WHO. Or the 4th criteria is that there are classical symptoms of hyperglycemia, which is polyuria and polydipsia, plus a random blood glucose more than or equal to 200 milligram per deciliter or 11.1 millimole per liter. We all know about the importance of an HbA1c for the diagnosis of diabetes, plus to monitor the control later for the diabetes. So HbA1c is a measure of the amount of glucose attached to hemoglobin in red blood cell. And it's an index of the average glucose over the preceding weeks to months. The level of HbA1c at any point of time is contributed by all the circulating erythrocytes. And we know that the half-life of the erythrocytes are 120 days. HbA1c is a weighted average of blood glucose level during the preceding 120 days. It means that the glucose level in the preceding 30 days will contribute more to the level of HbA1c than the glucose levels near 90 to 120 days earlier. بمعنى أن ال HbA1c يعكس لي ال average blood glucose throughout the 120 days preceding the check, but mostly reflect the last 30 days. In the DCCT study, which is Diabetes Control and Complication Trial, and this is a very common and well-known study about the pediatric diabetes, they recommended that the HbA1c should be checked every 3 months. And the result of the HbA1c, we can detect or estimate the average glucose based on the number of the HbA1c that we will get. In the table here shown, we can see that according to the number of the HbA1c, we can estimate the average blood glucose in milligram per deciliter and in millimole per liter. So it gives us an idea about the control of diabetes in this patient. Recommended حاليا ال HbA1c to say that we have an excellent control for diabetes for pediatric and adult age group are less than 7.5%. So less than 7.5% HbA1c is the recommended target for the excellent glycemic control in pediatrics and in adults. The HbA1c has a special recommendation according to the ADA criteria, American Diabetes Association, plus the NGSP group. The HbA1c test should be done by a method that is certified by the NGSP, and the NGSP بالعالم هي National Glycohemoglobin Standardization Program. Marked discordance between the measured A1C and the plasma glucose level should raise the possibility of an A1C interference, and we should repeat this A1C. بمعنى, in the clinic, we had a pediatric case of diabetes or even an adult, and we can see that all the documented blood sugar readings are high, all above 200 and 300 milligram per deciliter. At the same time, we did the HbA1c and we found that the HbA1c is 7.5. So there is a discordance. It means that HbA1c is not reflecting the glucose readings that I am seeing documented by the patient. Here, first thing I need to think about how this HbA1c assay was done. And there is a possibility of an interference, so I should repeat the test. Or the other possibility is that relation ما بين ال HbA1c وال blood glucose reading are usually altered by having a disease with an increased blood cell turnover. بمعنى الدليل أو المثال الاعتيادي على هذه الكيسات اللي هي الهيموغلوبينوباثي. Any hemoglobinopathies like الألفا ثلاسيميا, البيتا ثلاسيميا, sickle cell disease will alter this relationship. It means HbA1c will not reflect the glucose reading, and there will be a mismatch or a discordance between both readings. The examples about the cases that alter this relationship apart from the hemoglobinopathies, the pregnancies. So in pregnancies, especially the second or third trimester and postpartum period, it's not recommended to measure the HbA1c because it will not reflect the actual blood sugar readings. G6PD deficiency, the HIV, if the patient is on hemodialysis, or if there is a recent history of blood loss or a transfusion, or the patient on erythropoietin therapy. All these diseases alters the RBC's half-life, alters the relationship between the A1C or blood sugar control. So if your patient has one of these cases, do not depend on the HbA1c to diagnose diabetes or even later to monitor the control of diabetes. And here we have the option of using continuous glucose monitoring or actual blood sugar readings. And there is another measures like the fructosamine or the 1,5 anhydroglycotor are available, but المشكلة فيها في الفركتوزامين and the others, they indicates for you about the control of diabetes. Half-life of the fructosamine is 15 days compared to A1C, which reflects the last 120 days. And the other thing, they usually do not correlate with the average blood sugar. So their prognostic significance are not clear as the prognostic significance of an HbA1c and the average glucose. Now we'll go to the main talk of our presentation today, which is the etiological classification of diabetes. In 1997, the ADA published a revision of the classification of diabetes based on the etiology, which were modified again in 1999. Initially, the old ages, we used to define diabetes and classify them based on insulin-dependent and non-insulin-dependent. So we used to say type 1 diabetes and insulin-dependent diabetes, and type 2 as a non-insulin-dependent diabetes. But after our understanding of the pathogenesis of the various forms of diabetes, this classification based on the treatment, insulin-dependent or not insulin-dependent, is not anymore appropriate, and we should avoid using these two terminologies. So now we will see that what is the new classification of diabetes, which has been published by the American Diabetes Association Expert Committee and recently updated in their 2021 guideline. Why we need to know about the classification of diabetes? Because as I mentioned, it is important for determining the therapy, because some types of diabetes, as I mentioned, some types of the neonatal diabetes will moody, their treatment will be other than the insulin. The old idea previously that the type 2 diabetes will happen only in adults and the type 1 diabetes will happen only in children, this is not anymore accurate, because both diseases can be seen in both age groups. بمعنى, pediatric cases can be affected by type 2 diabetes, adult cases can be affected by type 1 diabetes. Children with type 1 diabetes typically present with the hallmark symptoms that we know of polyuria, polydipsia, and 1/3 of them will come with the presentation of a DKA. There are occasional patients with type 2 diabetes who again present with DKA. بمعنى DKA is a typical presentation of type 1. لكن في certain number or rare numbers of type 2 diabetes pediatric cases can present with DKA. So what is the latest or the updated classification and diagnosis of diabetes according to the ADA 2021 guideline? It is classified, the diabetes is classified into 4 general categories, and this is classification applied to pediatrics and adults. Type 1 diabetes, which is due to beta cell destruction, and this leads to absolute insulin deficiency. Type 2 diabetes is due to a progressive insulin secretory defect because of the insulin resistance. Gestational diabetes is diagnosed in the 2nd or 3rd trimester of pregnancy, and this is not a clearly overt diabetes. This is related to pregnancy. Specific types of diabetes due to other causes, which is called monogenic diabetes syndrome. Examples, neonatal diabetes, moody, or which is a maturity onset diabetes of the young, and cystic fibrosis related diabetes, drug or chemical induced diabetes, such as the treatment of HIV and after organ transplantation. So these are the 4 important categories for diabetes classification in pediatrics and adult. Type 1, type 2, gestational diabetes, monogenic diabetes, and diabetes related to other syndromes like cystic fibrosis and chemical induced diabetes. Type 1 diabetes, well-known, typical, that we all know is due to beta cell destruction and absolute insulin deficiency. And it's divided into 2 types. Type 1A, which is an immune-mediated, and here we can see the typical autoimmune antibodies for the pancreatic beta cell, like anti-insulin antibodies, anti-GAD antibodies, anti-islet cell, and anti-IA2 antibodies. And all these are antigens of the beta cell. Type 1 diabetes might have an absence of this immune-mediated process. It means that we will do antibody and it is negative. And this will not rule out for us type 1 diabetes. It will stay as a type 1 diabetes, but this is called type 1B or the idiopathic type 1 diabetes. It means we don't have an evidence of an immune-mediated destruction of the pancreatic beta cell, but it still behaves like type 1 diabetes and needs an insulin treatment. And there is a complete or absolute insulin deficiency. Type 2 diabetes, it usually reflects insulin resistance, and currently the number are increasing of type 2 diabetes in pediatrics because of increasing obesity, pediatric obesity. This graph has been obtained and up to date, again related from the search study, and here they classify the diabetes in pediatrics. Mostly, or around 54% of diabetes in pediatrics are autoimmune, which is type 1A. الأذرز اللي هي type 1A with obesity. It means إذا البيشنت عندك جاك بالtypical presentation of type 1 diabetes, polyuria, polydipsia, and DKA, and he has obesity, he has two options. Either this patient is having a type 1 diabetes and he is obese, بمعنى if we will search for the autoimmune antibodies, we will find it positive and he behaves like a type 1 diabetes, but he is also at the same time obese. Or he has a type 2 diabetes. ال 10% اللي هم الرير اللي هم behaves like type 1 and they are type 1 but they lack autoimmune evidence and they lack antibodies, and this is called type 1B. Around 15% of the cases will be type 2 diabetes. These are the common causes of pediatric diabetes and the commonest phenotypes of diabetes. The others, the monogenic diabetes, we'll talk about them later. Type 2 diabetes has variants related to the genetic defects of insulin and action. And usually it's type 2 diabetes is acquired due to the insulin resistance and obesity, but it might be a genetic defect of insulin action causing the insulin resistance, genetic insulin resistance. This is seen in Rabson-Mendenhall syndrome, lebrikonism, lipoatrophic diabetes syndrome, and type A insulin resistance. Or it's an acquired defect of insulin action, like the endocrine tumors, which is rarely seen in childhood, pheochromocytoma, Cushing, and other causes, or the presence of anti-insulin receptor antibodies, examples seen in SLE and other autoimmune diseases. So they behave like an insulin resistance, but the etiology behind the insulin resistance is not obesity. Diabetes can happen with diseases of the exocrine pancreas, like a pancreatitis, trauma, or after pancreatectomy. If there is a pancreatic neoplasia, cystic fibrosis-related diabetes, and hemochromatosis-related diabetes usually seen in beta thalassemia patient on regular blood transfusion because of the iron overload and the iron deposition in the pancreas. So they will have a special type of diabetes called hemochromatosis-related diabetes. It might happen after infections like congenital rubella, cytomegalovirus, or hemolytic uremic syndrome, or sometimes diabetes can happen after or drugs, use of special drugs, and this is called the drug or chemically induced, like examples, the well-known examples, the glucocorticoid, diazoxide, the thiazides, and the atypical antipsychotic medication. The other monogenic diabetes related to a special gene defect. The classical examples about it is the Moody syndromes, and we have six Moody type of diabetes happen in pediatrics or in adults. From Moody 1 to Moody 6, there are special genes affected because of that. It's called monogenic diabetes. Mitochondrial DNA mutation, like in Berson and Kernsteyer syndrome, they have also diabetes. Wolfram syndrome or DID mode, here this patient will have diabetes mellitus plus diabetes insipidus, optic atrophy, and deafness. And there are a special or a rare type of diabetes called thiamine responsive diabetes. The genetic syndromes where sometimes insulin resistance can happen and these patients can be affected with diabetes are Prader-Willi syndrome, Down syndrome, Turner, Klinefelter, Bardet-Biedl, and Alström. Neonatal diabetes is another form of monogenic diabetes, and we have two types, either the transient neonatal diabetes related to chromosome 6 abnormality or mutations in the gene of the potassium channels, the KCNJ11 and the ABCC8. Or the permanent type of neonatal diabetes, which does not resolve beyond the age of 18 months, and this is due to agenesis of pancreas or glucokinase deficiency or homozygous mutations in the potassium channel receptors, KCNJ11 and the ABCC8. Last type of diabetes is the gestational diabetes, and we'll not talk about it today. Type 1 diabetes, we talked about it. It's again an immune-mediated, and there is an absolute insulin deficiency with an evidence of the presence of an autoimmune antibody circulating in the blood. If we'll do antibodies, they will be positive. And there is a lymphocytic infiltration in the islet cell early in the disease, and there is a coexistence with the other autoimmune diseases. بمعنى patients with type 1 diabetes are more prone to other autoimmune diseases like Hashimoto thyroiditis, Addison disease. We need to screen these patients for other autoimmune disorders. We talked about the type 1B اللي هم behaving like type 1. They are type 1, but they lack the circulating autoimmune antibodies for the pancreatic beta cell, and they happen as an abrupt onset throughout the childhood. They are not associated with the special HLA types, لأن التايب 1B احنا بنعرف إنه associated مع ال HLA special HLA typing، لكن التايب 1B is not associated with this HLA typing, and there is an evidence of insulinitis in the pancreatic biopsies. بمعنى there is a high concentration of pancreatic enzymes. There is an evidence of an acute inflammatory process in the pancreas, but there is no circulating antibody and no autoimmune destruction for the pancreas. It's called نعم.
رومانيل
تفضل.
قدام حضرتك كتير عشان الوقت بعد إذنك؟
لا معاي كم يا أخ محمد؟ ألو.
أيوة مع حضرتك.
أيوة 10 minutes أو 5
يعني
minutes.
لا يعني هيبقى ماكسيمم 5 minutes.
يلا اوكي حاضر ان شاء الله.
ماشي شكرا.
Okay. Type 2 diabetes, as I said, the cause of insulin resistance is usually obesity, and it might happen in pediatrics and the adult age group. Treatment of type 2 diabetes is usually starting with the insulin, and we can start with the metformin according to the severity of the symptoms that the patient will present. They might present with a DKA and metformin, which sensitize the tissue to the insulin action and diminish the hepatic glucose production, is the most frequently used agent to treat type 2 diabetes for children. في patients of type 2 diabetes بيكتفوا فقط بالميتفورمين وبيكون كافي to treat their diabetes, but most of them, especially with the obesity, they require the addition of insulin. بس حبيت أوضح بهذا التيبل اللي هو obtained من الاب تو ديت الفرق ما بين التايب 1 والتايب 2 diabetes because they are the commonest type of diabetes in children. Ketosis at onset is usually common in type 1 but rare at type 2. History of affected relatives are rare in type 1 but it's common in type 2. Strong family history of type 2 diabetes is there but نادرا ما نشوفها في type 1. HLA special HLA typing DR3 with DR4 is there in type 1 but not there in type 2, and usually type 2 patients are the obese. Type 1 patient might be obese in 20 to 25% of them, but typically not. Pancreatic antibodies present in type 1, not in type 2 diabetes. about the variants of type 2 بس أذكر حضراتكم بأنه في genetic defect بالإنسولين action causing genetic insulin resistance. علامة الأكانثوسيس nigricans هي typical to indicate the insulin resistance. This insulin resistance is usually associated مع obesity, but it might be related to some genetic disorders like a type A insulin resistance, type B insulin resistance, and because of the time, but I'm not able to talk about them, leprechaunism or a Donho syndrome. It's a very severe disease caused by congenital insulin resistance, present with diabetes after birth. The patients بيكونوا IUGR having fasting hypoglycemia but postprandial hyperglycemia. There is a defect in the insulin receptor causing this insulin resistance, and they usually, most of them die during the first year of life. And we can see that severe acanthosis nigricans they have. Rabson-Mendelhon syndrome is another type of insulin resistance. It's usually milder form, compatible with life. It's again another form of congenital insulin resistance. وفيهم بيكون widespread acanthosis nigricans. Because of time, I'll just talk a little about the Moody diabetes. The Moody syndromes are examples of monogenic diabetes. They account for 2 to 5% of pediatric diabetes. There is usually a strong family history of a vertically transmitted diabetes in all the generations. بمعنى إذا أخذتوا detailed family history هتشوفوا إنه diabetes present in 3 generations. And this strong family history of diabetes give you a hint that I might be dealing with Moody syndrome. And there is no autoimmune markers because it's a monogenic type of diabetes. The commonest is Moody type 2, and في Moody type 5, the patients will be affected with diabetes plus the presence of renopelvic anomalies or renal cysts, and the Moody 4 is due to a pancreatic agenesis, so the patients will have a blood diabetes, exocrine affection of the function of the exocrine insufficiency of the pancreas. Because of the time, I'll just pass here. One slide about neonatal diabetes. The incidence is 1 in 100,000 births. It's 2 types, transient or permanent, and both forms, either transient or permanent. The babies affected by neonatal diabetes are usually IUGR, and this reflects the critical role of insulin in utero growth factor. They present after birth with polyuria, glycosuria, and dehydration. They have failure to thrive, and occasionally they present with a DKA. And if we will measure the insulin and the IGF-1, they will be low. The treatment with insulin, it will cause a dramatic catch-up growth. And just remember that there are certain types of neonatal diabetes related to potassium channel subunits. If this activating mutation detected by genetic test of a neonatal diabetes case, then their treatment will not be insulin. They will be treated with the oral sulfonylurea like the glibenclamide. وهذا اللي هو الكاركترستيك بالنسبة لها type of neonatal diabetes. I will not talk about this. I will just finish my slides by talking about cystic fibrosis related diabetes. It's a non-immune form of diabetes due to the pancreatic insufficiency. They might present with a diabetic ketoacidosis and is common in cystic fibrosis patient. And we should start screening about diabetes in cystic fibrosis patient from the age of 10 years and above, or typically not by the HbA1c. They should be screened by the OGTT. Finally, the conclusion is that diagnosis of diabetes is established based on the ADA criteria. Just remember as a take-home message that not all pediatric diabetes is type 1. Think about other types of diabetes if you have a neonatal occurrence or below the age of 6 months, if there is any other associated symptoms, if there is an exocrine manifestations, strong family history in 3 consecutive generations, or obesity with evidence of insulin resistance, acanthosis nigricans. All this indicates that I might be dealing with other type of diabetes rather than type 1 diabetes. Thank you so much, and sorry for the delay.
شكرا لحضرتك يا دكتور منال. دكتور محمد زنون معايا.
أنا آسفة على التأخير دكتور محمد.
شكرا دكتورة منال على التوك الجميلة دي. أنا ما رحبتش بيكي في الأول لأن طبعا دكتور محمد زنون تولى تقديمك الحقيقة مشكورا. نورتينا ويا رب دايما معانا إن شاء الله. برحب كمان بدكتور محسن الصعب لأن هو أنا لقيته دخل معانا. منورنا يا دكتور محسن.
شكرا دكتورة.
دلوقتي بقى دكتورة إيمان هتقدم دكتورة منى عبد المطلب.
دكتورة إيمان المايك يا دكتور. المايك يا دكتور إيمان. المايك ميوتد يا دكتور.
Yeah, it's okay right now. Hi, everybody. Have a nice weekend for you all. First, I would like to thank sister, colleague, Professor Dr. Hala for inviting me for this very, very interesting and impressive virtual conference. And unfortunately, it's virtual, but I feel that it's so intimate. Yeah. Thanks for all the speakers. Thanks for my colleague chairpersons. We are all in our department, Child Health Department. I am the chairman of this department at the National Research Center. I'm so proud of the eminent professors, Professor Hala Nedi, the president of the society and this conference, and also Professor Speaker right now, Professor Dr. Ines Rafat. It was a very, very interesting presentation. And now the other presentation, and also very impressive for me from my side because it's about the nutrition. It's my specialty. Dr. Mona Abdel Muttalib, she is a consultant of internal medicine and chairman of the nutrition unit at the National Institute of Diabetes and Endocrinology. Actually, we have the same topic maybe 2 weeks ago, but I'm very anxious and I can't wait. Looking forward to a very impressive talk right now.